Dr. Sanjay Saran is with me, and there's a very important confusion because medical science now today in today's world is basically big of confusions. The various guidelines comes from this end of the country to that kind of country in the world. There is a big confusion. So in diabetes, the biggest confusion is pertaining to the glycemic targets, pertaining to the diagnosis of diabetes, and there are two varied different guidelines say that this much sugars are okay, this much HbA1c, glycated hemoglobin is okay. A different guideline says that this much is the A1C, which is the cutoff. So I want to ask Dr. Sanjay pertaining to that whether this difference in guidelines has an importance to the patient oblique to the medical fraternity.
First of all, treatment of diabetes mellitus should be individualized. Should be individualized on the basis of the life expectancy of the patient, age of the patient, cost of the treatment, also the polypharmacy, adverse effect. These on basis of these things should be individualized. Most of the guidelines, most of the recommendations, most of the society organizations, they recommend treatment of diabetes mellitus should be individualized. So as far as other recommendations are concerned, that ADA recommended that HbA1c target should be less than 7 in non-pregnant adults. As ACE recommend it should be in between 6.5 to less than 7 in non-pregnant adults. But recently ACP has recommended, American College of Physicians has recommended that it should be in between 7 to 8 in non-pregnant adult. So there's a lot of controversies there regarding that guidelines. So ACP has recommended it's on the basis of the few landmark trials like ACCORD trial. In the ACCORD trial, they have seen a lot of cases of hypoglycemia and also cardiovascular mortality and also all-cause mortality that was higher in case of intensive control of the blood sugar as compared to standard control. Where in the intensive control, where they put the HbA1c less than 7. In case of standard control, they have kept the HbA1c in between 7 to 8. So if we see compare the intensive arm and standard arm, so because of this all-cause mortality high all-cause, high cardiovascular death, and high risk of hypoglycemia and more severe hypoglycemia in case of intensive arm, and there were no significant increase in the microvascular or macrovascular complication in case of a standard arm. So according to ACP, they are saying in this ACCORD trial, if with the keeping the target little bit relaxed in between 7 to 8, we will not face many risk of hypoglycemia, will not face the high risk of mortality, will not face the more cardiovascular mortality. So it is better to keep it in between 6, 7 to 8. As far as other trials are concerned, like VDT trials, so here also in trials they have seen a lot of cases of hypoglycemia, and there was no major difference in between micro and macrovascular complications, though they have shown some benefit in terms of microalbuminuria, but clinical evident nephropathy benefit was not seen. As far as other benefits are seen, no retinopathy benefits are seen in case of VDT trials. Again here, the mortality was not different in comparison to the standard arm or intensive arm, but if we don't see any kind of benefit, then why should we put the patient on the risk of hypoglycemia? So again, the third trial, that was the advanced trial. In advanced trial also, they have seen the high mortality, but it was not so significant. But again, the risk of hypoglycemia was more. Even the neuropathy, particularly autonomic neuropathy, was more in intensive arm. But benefits was seen in terms of only microalbuminuria, that was seen more in case of the standard arm as compared to intensive arm. So on the basis of these three trials, mainly they make the guidelines to keep the patient on the HbA1c in between 7 to 8.
But what will be your take-home message for that? That how the patient should interpret it, that whether the HbA1c is, which is the HbA1c which is normal for the patient or for the diagnosis of diabetes?
Yeah, as I already say, treatment should be individualized. If the patient is young, well educated, then we should keep the HbA1c as low as possible. And if the patient is older age or very small kids, in those cases where the morbidity is also there, and other conditions like life expectancy is less than 10 years is there, and also patient is having other disease like cardiac disease or like that, at that time we can keep the HbA1c a little bit relaxed in between 7 to 8, or in some cases it can be kept more than 8.
So individualization is the key. Thank you very much, Sanjay.
Individualization is the key of the
Thank you
treatment.
very much for this basic introduction. Thank you.